My name's Chris Bates. I work at TPP as the Research and Analytics Director. So I work with Frank Hester, who gave the keynote speech this morning. I'm a software developer and a data scientist with a background in mathematics. I want to talk about how we unlock the full potential of the EMR, building on some of those things that Frank said. And I think, we all know that the argument is proven that the EMR brings massive benefits. And one of those things is having that information at fingertips. I think best summed up by the idea that people only tell their story once. But there's other challenges that we share. There's other shared challenges across the world, challenges that are perhaps best exemplified in the ASEAN region, with a very large population, really diverse geography, really diverse socioeconomic factors. Some areas with very, very young populations and some areas with aging populations. Every single global health care challenge comes together here. And I want to focus on those challenges, and that is building on, actually, I think 4 years ago we were here where the previous Health Minister, Dr. Zul, launching the National EMR programme here, said, look, in digital health, we're not judged on the technology we procure, we're going to be judged on outcomes, and I think that is something to live by in this sector we work in. So what are some of those challenges? Well, very quickly, we all know them. That rise of non-communicable diseases, the increase in ageing population, the rising lifestyle factors that affect that. The incidence we have in cancer burden around the world, and the impact that has on healthcare services and the impact that has on families and people. And infectious disease management, of course, we've seen that very strongly over the last 2 years, but we have endemic problems in many, many countries. And in the region, TB, HIV, hepatitis, diarrheal disease, these are real problems. And you can't really separate these things on this top row. We know that people who are living with chronic kidney disease are much more likely to die of respiratory problems. So we have to take this as a whole, as an integrated whole. And at the bottom, workforce pressures. There's always pressures with a growing population on the numbers of doctors, the number of nurses, the number of midwives. We know this. No country, as Frank said this morning, has a surplus of healthcare workers. Increasing healthcare expenditure and cost, from insurance to out-of-pocket to Ministry of Finance budgets really being stretched. And finally, as Dr. Mahesh said on a panel just before lunch, those changing models of care and policy, moving towards remote monitoring, moving towards apps. So these are complex times that we work in, broad and multifaceted challenges. So what I want to talk about are real-life examples of where big data and artificial intelligence can help. So things that are actually happening in practice rather than things that are potentially we're talking about in the future. And really, the overriding thing is what's possible if we have national-scale EMRs, what's possible if we go with the ambition of embedding intelligence at every person's contact with a health service. If we can do that, what can we do? Just to put some very quick context on it, at TPP, we are used to working with big data. So we supply solutions to over 8,000 organisations worldwide, in the UK, in China, the Middle East and the Caribbean. We've recently just gone live in KPJ here in Malaysia and have been actively working in Malaysia for several years. And we host on a single platform more than 52 million records, and that's a comprehensive EMR, all symptoms, diagnoses, blood tests, medical history, everything you can imagine on that longitudinal EMR. And this is what I'm going to talk about. It's the possibilities when you have that in place. Where to start? Well, I'm going to start with cancer. And I'm going to start specifically with ovarian cancer. One of the reasons being it's a real shared challenge for us. The highest rates of ovarian cancer anywhere in the world are in Northern Europe and in Southeast Asia. So it's a problem we have. And actually a problem that the health minister here highlighted only 6 or 7 weeks ago. That in Malaysia, we're in the situation where over 80% of ovarian cancer diagnoses happen at stage 3 or later. And if you look at that graph there on the left-hand side, you can see that the survival percentage drops off remarkably after stage 2. What does that mean? It means we need to left shift. It means we need to identify people as early as possible. That means we need to identify from patients themselves, from primary cares and clinics, if we're going to improve survival rates. It's difficult to diagnose. It presents as many other things. It's a real challenge for clinicians, and it's a challenge that was highlighted back in the UK 3 years ago as well by our Prime Minister at the time, who said, ovarian cancer is one of the things we need to try and to tackle. And that's what got us as an organisation thinking about that hard. What did we do? Well, we turned to machine learning to do that. And if you have symptom data, if you have biochemistry data, full medical history data, and you have millions and millions of records, then the possibilities of using machine learning to give you the intelligence to do that becomes a reality. So we were able to do that, we developed it. What was the outcome of that? Well, 50% of the time, appropriately, the algorithm flagged up before the GP had considered it, that the woman should be considered for screening for an undiagnosed tumour of ovarian cancer. What that means is we pull staging back. We get people earlier, we get better prognosis. We use this with our GPs. This has gone live into the system, working with some charities and GPs with special interests, and they adore the idea of this. So it gives them the nudge in primary care to say, have you considered ovarian cancer? So, a doctor who will see very, very few cases of this gets the support with the algorithm. And that's what we're talking about here. We're talking about augmenting clinical practice, not the machine taking over, but it helping doctors to do that. Can we put that into the ASEAN region? Undoubtedly. Would we need to consider local epidemiology? Do we need to think about how we need to retrain and do that? Yes. But working together with the basis of that algorithm and new data collection across the region, we can have appropriate algorithms in the area to help try and tackle this problem everywhere. Key to that information was getting that algorithm was getting that symptom information out. You want to know about a patient's symptoms. And as Frank said earlier, nowhere is this more important than in infectious disease. You need to know about those symptoms. But often, they're not coded in a nice way that as a data scientist you can immediately run analysis on. You just can't do that. They're often in the text. But again, this is where machine learning gives you massive power. And we saw this during the pandemic. So we could see in the pandemic that we weren't getting coded, even the symptoms we expected for fever, for continuous cough, for example, that often they weren't in a nice way that was coded that we could run the analysis on. And on top of that, of course, there's very, very complex ways of doing that. There'll be no continuous cough. There's different ways of, doctors and nurses will come up with every way possible to write things in text, which make it difficult to know exactly what's going on. But machine learning has moved on a long way. You know this from voice assistants you have at home, that they can really understand language very, very well. So we were able to take this technology during the pandemic, apply it to all the narrative text that was being entered around the country by doctors and nurses, and get accurate prediction of where outbreaks were happening, down to individual geographic areas. It meant we could warn public health authorities. There were certain areas where there was factories where people were working, but we knew there was outbreaks happening there. There were public transport routes where we could see exactly that there was an outbreak problem. So it gave us the ability to do that. And more than that, it enabled us to find some of those new symptoms that we didn't know about and were only anecdotal. So loss of smell, for example, when you turn the technology onto it, out comes that as a prevalent symptom, and you can use that to improve your tracking. What the possibility is going forward is we track for all those symptoms. For all 1,100, 1,200 symptoms that we know about in healthcare literature, that we track those symptoms continuously across national EMRs so we get the earliest warning detection as possible, but also we get those new case definitions of emerging problems as soon as we can. COVID brought with it many policy questions as well. Policy questions that governments needed to answer. And again, I go back to Dr. Zuhl. What are the real outcomes we could get from this? So using that national EMR infrastructure, during the COVID-19 pandemic, we were asked by our Chief Scientific Advisor and Chief Medical Officer in the UK, along with the government itself, to work with our major universities, so in particular Oxford University here, to create a massive EMR platform for research. And why do we want to do that? Well, we needed to know what those major risk factors were for people. What were the clinical risk factors that meant people may have poor outcomes from COVID? What were the demographic risk factors that were there? What we could do is we could run this massive analysis on nearly 20 million comprehensive records. So all the secondary, all the hospital data, all the testing data, all of that medical history data to give us the world's largest study into risk factors for COVID. We did this in a 6-week period, from a standing start to this analytics database in 6 weeks. And the first output here was published in Nature, and it gave us that ability, so it answered policy questions. But once you've built that infrastructure, we could go on from there and keep asking the questions that the health services wanted to know the answers to. So at the time, is it safe to use ibuprofen or should we have patients on paracetamol? If we've got asthmatic patients, is it safe for them to continue using their inhalers? We were able to answer questions about HIV, about vaccine breakthrough, about the gaps we should have between vaccine doses. As new treatments came on board, we could see how effective those treatments were being, all because we'd built that infrastructure. So the point being, if you have this national EMR infrastructure in place and you build the platform for research once, then governments, ministries of health and agencies can ask the questions they want to ask and get those answers immediately. But of course, it's not the, COVID is an epidemic we have, but we have many epidemics and epidemics in long-term conditions. And bringing together those two, as I was saying at the start, that we can't decouple these things. COVID was a virus that preyed on people with long-term conditions. If you had uncontrolled diabetes or uncontrolled chronic kidney disease, you were very, very at risk of poor outcomes. But we can use exactly the same technology, this machine learning technology, to move on to long-term conditions. So this is actually work that was done by an Israeli team, but work we were able to replicate a few years ago, pre-pandemic, around diabetes control. And what this showed was, we tend to have national targets for diabetic patients. We certainly do in the UK, do here in Malaysia, and do around the world, which is we have a standard pathway for diabetics. You should aim at these biochemical targets. But using the technology and using big data showed us that's not the case. So, for example, there are 3 clusters of diabetic patients based on their HbA1c trajectory, so a certain biochemical indicator. There are people who are stable, people who are descending, people who are ascending. The interesting bit is if you want to stop those people having complications of diabetes, the things that, really poor outcomes for people, eye problems, foot problems, kidney problems, then it's better to have individualized targets. So we're moving towards personalized medicine. So if you are in one of those clusters, you get different advice from the healthcare services, different targets to aim at, and it stops you going down a worse trajectory and having poor disease progression. We know that's there right now. What else is going on in that space? Well, lots, and lots of evidence-based work. So here's 3 examples, one of which based on research data that we could provide. It's colleagues at the University of Leeds and others at the University of Nottingham, where they're using machine learning to have better and better risk prediction algorithms for people who've got undiagnosed atrial fibrillation, for example, and then cardiovascular risk prediction, far better than the existing models that exist in clinical practice. And at the top there, people turning this onto rare conditions. Now it sounds, it's different from those high prevalence conditions we're used to talking about. But rare conditions, when you take them all together, are about 10% of all diagnoses and have a tremendous burden on healthcare services. So if we can start to use the machine to tackle those, then we start to get better decision support in our systems and better outcomes. So your EMR vendors absolutely have to be able to run machine learning in their system if you're going to stay at the forefront of digital healthcare. From there, I want to just on talking about atrial fibrillation, this is the kind of link, but it goes to Dr. Mahesh this morning, talking about changes to remote monitoring and what can we do that enables us to get more capacity using this technology. So this is our patient-facing app. This is AirMid, which we've recently gone live with in Malaysia at KPJ. And AirMid means that every single patient gets access to their own personal health record that links to their electronic health record, but importantly allows you to do continuous remote monitoring. Some of that monitoring may be from personalised questionnaires you can put in, for example, for post-discharge support, but some of it's automatic using the kind of technology we're used to on smartphones and devices. So what are they? So Dr. Mahesh mentioned pulse oximetry. And of course, this means that you can have a cheap pulse oximetry device if you were living with COVID and staying at home. You can monitor those things via Bluetooth. It connects to the app, via the Google Fit API or via Apple Health Kit, which are just standard pieces of functionality on these phones, and then link straight to your medical record. So you can alert care teams immediately if someone's going out of control using this technology. As another example in long-term condition management, if you have heart failure patients, we need to know if heart failure patients are if they're weighing themselves, if they're starting to put on weight, means they're probably retaining water, they need a medication change. This normally can't happen, but the technology means it's possible. You have Bluetooth scales, the patient weighs themselves every morning. If there's an increase in weight, then it just flags the care team and they need to get a change in their medication. It's incredible technology, it makes a difference to people, but it's happening right now. Workforce. So as much as we might be able to use remote monitoring, for lots and lots of different conditions, we're never going to get away from face-to-face appointments. It's massively important. And this is community nursing in the UK, and this is a thing that's more complex than you may imagine. What we need to do is get nurses out to visit people, possibly in very remote rural areas, and this can be elderly patients, patients with diabetic needs, new mums, for example. So you need to make sure you're getting the right nurses to the right people at the right time. It's massively important. If you don't do that, if you get the wrong skill set there, or you're not doing it in the most efficient way, you can burn really important time for doctors and nurses. So we implemented an algorithm As you can imagine, any of the computer scientists in the room, it's kind of like a traveling salesman problem. What's the best way of me getting around numerous sites? But it's more complex than that, and it needs the EMR underneath it, because you need to make sure you're getting the right staff member to the right patient, and you're not having a wasted journey. So we were able to put that algorithm in place, and you can see the results there. So from 31% contact time with patients to 71% contact time. So an increase in 40% of time that nurses were able to spend with patients just because the machine's in place. And just as importantly, no patients now on the waiting list. So nobody waiting for treatment because of having that national level EMR and having intelligence built in at that point, which enables people to maximise the time they can spend with people. It's massive. And another example on top of this, we were asked, we have a big problem in the UK, and actually around the world, this is a significant problem with people not attending clinic appointments. So there's an appointment being booked, the patient doesn't show up, and it's a wasted amount of time. Again, we've got an algorithm in the system now, which has been used for over 2 years, which accurately identifies exactly who's not going to turn up to an appointment. So what can you do then? You can send the patient a notification on their app, you can send them an SMS. You may decide to overbook that clinic so that you're not wasting valuable resource. So again, using that information, using that data enables us to do that. When those nurses are travelling around, what do they need? Well, they need access to information about the patients. There's no point in us having an efficient way of routing people around if they can't see a patient's allergies, if they can't see their long-term conditions, if they can't record the observations about the patient at that time. So this, again, moving the EMR towards static-based to mobile-based. So this is our Bridget app, which again is now being used in Malaysia. And that enables doctors and nurses to work on the go. Now, does that mean that means in the ward, but it also means out in the community or even at home? They can record observations, they can see patient records, they can coordinate their workflow. Exactly. Another question is, who exactly should we intervene with? So this is one, if you imagine those nurses seeing elderly patients out in the community, and this was a big initiative in the UK about 5 years ago, which was to try and target, for elderly individuals, it's really easy to see a 90-year-old and presume they're much more frail than a 50-year-old, and it's just not true. Using chronological age to determine someone's clinical frailty it's too blunt a tool. It doesn't give you the accuracy you need. So we were asked by the NHS to work with universities in the UK to develop an algorithm to enable us to say how frail somebody was using their routinely collected electronic medical record data. The problem was we had lots of elderly people who were getting a small healthcare problem, maybe a small infection or a fall. But when that happened, because they were a frail individual, they may end up in hospital. So at that time, they're into crisis when they don't need to be. And then they get an assessment about their geriatric state, but it's too late. But when we've got the electronic medical record data, you can do that automatically to target exactly who in the community needs an intervention. And it may be a simple intervention. It may be they need an eye test. It may be they need a handrail outside their house. It may be that they need a medication review. So we developed an algorithm that uses about 3,000 different data points and stratifies people into 4 categories. So fit, mild, moderate, severe. What that means, it's now part of national policy for elderly care management in the UK. What it means is that people get on the right care pathways. It might be just supported self-care management that they can do from a phone and education advice, all the way down to end-of-life care pathways when we need to make sure that they've got everything in place for a dignified death. So it's made a massive difference to patient outcomes. We've stopped people getting frailer and frailer. We've got them on the right trajectory. If I take you to the bottom left, it's made a massive difference to healthcare costs. So the more frail people are, they disproportionately use a lot of the healthcare budget. We understand that. They have a lot of healthcare needs. But if we can shift people over time from severe to moderate to mild and stop people going there, we're saving a fortune for healthcare services that is stretched. So using the EMR and using the algorithmic data to actually change the costs of healthcare for a high proportion group. And finally, the missing piece of the jigsaw, if we're going to find exactly who it is that we need to intervene with, probably comes into the genomic sphere. And I think sometimes this is talked about in the abstract as to we will be able to do this, we might be able to do this, but this is really happening now. So this photo is a photo of a data centre in Manchester in the UK, where the UK Biobank data is held. So that's a 500,000 strong cohort of people who've got whole genome sequences in there for researchers around the world to access. What's made that powerful is being able to put national EMR data alongside that at a research level for the research teams to do their work on. So they've now got the genomes for people and all the static data that was collected at that point in time, but now a continuous longitudinal EMR to say, how are those people progressing in terms of disease and disease management? So, and that data comes from us at TPP. What's happening is they're using that, they're now coming up with polygenic risk scores, for example, which combined with EMR data give you the most accurate prediction of exactly who is likely to progress to long-term condition management that we can build into the system. We're now at the point where the array that they use to do the initial genome sequencing is $25. So it's a health economic argument that says it's probably worth us doing this for people so we can target the right people, stop them progressing to long-term conditions and stop them having that burden on healthcare management. So hopefully, in a fairly quick amount of time, I've given you an idea of what's possible with national EMRs and with the idea that every time a patient contacts a health service, we're trying to be intelligent with their data, we're trying to focus on outcomes and challenges, and we can make a big difference to outcomes and experience across the region. Thank you.